Hello and happy International Women's Day to everyone. On behalf of Turning Point, I'd like to welcome you to today's Connect and Learn webinar. These webinars are funded by the Victorian Department of Health to support the work of AOD clinicians. My name is Naomi, and I'd like to begin by acknowledging the traditional owners of the land on which we meet today, and to pay my respects to their elders, past, present, and emerging. I extend this respect to Aboriginal and Torres Strait Islander people who are with us today. I would also like to acknowledge any of our viewers who have or are being impacted by the devastating floods in the north of our continent and wish them well in the months of recovery to come. The topic of today's webinar is working effectively with people with a diagnosis of borderline personality disorder. We like all our webinars to be as interactive as possible, so please ask questions via the Q&A function. The questions will be collated and answered by our presenters at the end. Please be aware that our webinars are recorded and later made available on the Turning Point website. We encourage you all to stay till the end of the webinar and to complete the exit survey when the QR code appears in the last slide or via email later today. A copy of all the slides will be emailed to you. So now I'm very pleased to be able to introduce colleagues from our sister organisation, Spectrum. Spectrum is the statewide service for personality disorders in Victoria. And my colleagues who are speaking today are Andy Bauman and Kat Carla. Andy Bauman is a mental health social worker with 10 years experience working in public mental health services in Victoria. He has worked within community and acute teams and has developed a solid understanding of working with clients with BPD in a variety of settings. Andy is a member of the ACT team at Spectrum, providing individual therapy and group programs using this particular framework. Kat Carla is a qualified mental health nurse with over 15 years experience working in acute and therapeutic settings in Victoria, interstate and overseas. Over the past few years, she has worked as an emergency mental health clinician in a Metro Melbourne hospital, while also working part-time at Spectrum and in private practice. So over to you, Andy and Kat.
Thanks, Naomi, and thanks everyone for joining us today. Obviously, I'm Andy and this is my colleague Kat, and we're going to be delivering the presentation today. So in putting together today's presentation, I suppose we wanted to make something that was going to be useful for your service. And sort of thinking about things that were going to be informative and useful for you. So before we start, just want to make an acknowledgement of country. So we acknowledge the traditional custodians of the land on which we meet today, pay our respects to elders past and present and emerging, and acknowledge any First Australians who may be present with us. We would also like to acknowledge lived experience. So we acknowledge people with lived experience of mental ill health and recovery and the experiences of those who support them, including carers, families and supporters. The voices of people with lived experience inform our work. We recognise the vital contribution of lived experience at all levels and value the courage of those who share these unique perspectives for the purpose of learning and growing together to achieve better outcomes for all.
So a little bit of an intro of what we will be covering today. We will provide you with an introduction to Spectrum, what we do, who we are, what services we provide. This will be followed by an overview of the diagnosis of borderline personality disorder. And subsequent to that, we will be talking a little bit about when you as clinicians might want to think about whether your client has a diagnosis of borderline personality disorder or not. We will then sort of wrap things up by talking about how to work effectively with clients with BPD and also when to refer to other services and where to refer to, and that will also include Spectrum.
So we're hoping that the learning outcomes from today is for you guys to develop a bit of an understanding of the diagnostic criteria for clients with BPD, developing the ability to recognise symptoms of BPD and the associated formulations, explaining the principles of effective therapeutic relationships, and an awareness of supports available to people with BPD and criteria for referrals to specialist services.
What we won't cover today, and there is a lot, is etiology and factors that are contributing towards the development of borderline personality disorder, as well as risk assessments and crisis assessments and crisis management. These topics by themselves, we spend entire workshops, entire days on exploring those kind of topics. So if you are interested in those topics, or specifically in interventions and therapeutic modalities, or would like to explore things like transference and countertransference a little bit more, and the role of self-awareness when working with clients with BPD, we would invite you to actually visit our website and book in for one of our other training workshops that we provide.
So a little introduction to Spectrum. So as you're likely aware, Spectrum is Victoria's public statewide personality disorders service. It was founded in 1999. At the time, Jeff Kennett was Premier in Victoria. And essentially it came about due to a recognition that people with personality disorders were not being serviced very well, that they were often quite resource intensive patients, and that we needed to develop a peak body to develop and promote best practice with this group. It's estimated that the prevalence of BPD is at around 1 to 2% of the general population. So that's people that meet criteria for the diagnosis. That translates to around 60,000 to 120,000 people in Victoria. So it's quite a lot of people. It's often not recognised though. It's often poorly understood, and a lot of people don't receive adequate treatment for a diagnosis of PD. It's estimated that GPs see one person with personality disorder every day, and that they make up about 6% of people presenting to GP clinics. For area mental health services, that proportion is even higher. So they make up around 15% of psychiatric outpatients and around a quarter of psychiatric inpatients. So it's clearly a significant population, and people that are overrepresented in health services as well. So, what do we do at Spectrum? Well, we provide assessments for diagnostic clarification and for recommendation on treatments. Referral pathways to that can occur either via the GP or private psychiatrist, who can send a referral through to our reception for a Medicare assessment in our Medicare assessment clinic. Or area mental health services can directly refer to Spectrum for an assessment of their client with a request for potential for treatment. Our current treatment clinics in Spectrum are made out of 3 treatment clinics. There's DBT, which is, everybody's always familiar with DBT, and certainly our intake team receives a lot of requests for DBT or for referrals to other DBT services. So I think most people are familiar with dialectical behavior therapy. We also have the mentalization-based treatment program, and we've got the acceptance and commitment therapy. In addition to those 3 streams of treatment clinics, we then also have what we call the complex care service, and that service can provide direct treatment to clients, but also can provide systemic interventions for particularly complex clients. Or if that's maybe not, maybe the combination out of treatment and intervention isn't needed, the complex care service can also provide what we call secondary consultation to area mental health services primarily. And that is really to provide a space for clinicians and services to think about their work for clients with BPD, how to support each other, how to support a client, and how to manage some of those things that we talked about, countertransference and transference, and how to work effectively. In addition to that, Spectrum also does provide some fee-for-service consultations, which is outside of the usual referral pathways that we've just talked about. And most certainly, we've provided secondary consultation as well as treatment and systems intervention interstate or at the specific request of some other services. And generally this tends to occur because there are a lot of states that don't have specialist personality disorder treatment services like Spectrum. So we often get referrals from places like Tasmania or Northern Territory, for instance, who might not have a specialist body in their area. So other than assessment and treatment, Spectrum also provides research and innovation in this space. All of our treatment programs are evaluated, and obviously that's to improve practice and outcomes, but we're also sort of always trialing new ways of delivering service and trying to reach more people as well. And another part of that is our workforce development team, of which Kat and I are both a part of. So we provide training to professionals like yourselves, other people in mental health services, and a variety of other services, actually, just given the amount of different services that people with BPD often come in contact with. Spectrum delivers the national training strategy, so nationwide, delivering sort of core competency training to mental health clinicians, and train the trainer workshops to train clinicians within specific services to then train their staff. We also offer carer support workshops for carers and families of people with BPD. They're facilitated by our carer consultant, Rita Brown. And we have 2 annual conferences. So there's the annual BPD conference, and just recently we've had our first research conference.
So, which brings us to an overview of the diagnosis of borderline personality disorder. We only have we have a very time limited space. So we didn't just want to go through the symptoms, but we really wanted to talk about what actually makes up a disordered personality. What is the actual criteria when you start to think about, this might actually indicate that there is a personality disorder. And according to the DSM-5, the criteria for that is that there has to be an enduring pattern of inner experiences as well as outer behavior that deviates markedly from the expectation of the individual's cultures. And those enduring patterns have to be manifested in the following areas. First of all, there's a cognition, and with cognition we mean the ways that somebody perceives and interprets themselves, the way they interpret and perceive other people, and the events that take place. The enduring pattern also has to affect what we call affectivity, meaning the mood response range and intensity, as well as ability and also appropriateness of an emotional response within any given situation. And that, of course, as we know, is culture specific, and that's exactly why that criteria is in place. The enduring pattern of interpersonal functioning and also impulse control. And this pattern has to be inflexible, meaning has to be rigid and pervasive across a broad range of personal and social situations. And the reason that this is included is so that this isn't just something that this pattern occurs in one specific situation, once sort of due to particular connection or circumstances, but it's actually pervasive. And the continuing with that is that it leads to actually clinically significant distress and or impairment in a variety of areas of functioning, such as social function, occupational function, or other areas. This pattern has to be of long duration, and often what we know and what we have noticed is that this can actually be traced back to start already in adolescence or in very early adulthood. And a very important part is that this enduring pattern is not better explained as a manifestation or consequence of another mental disorder. So when a diagnosis of borderline personality disorder is made, that has to be made in a really thoughtful manner, and that has to be made in the context of a lot of collateral information that we receive. And so when people get referred to our assessment clinics, often there's already existing information from other healthcare providers that kind of give us that lifetime trajectory and the overall, impression of functionality. And this enduring pattern that we've talked about, this function cannot be attributed to any other physiological effects of either substance use or any other medical condition, because I'm sure most of you are aware, actually, when we look at some of those symptoms, things like impulsivity or difficulties in sort of relationship and navigating a sense of self and others can by itself be due to a whole range of other difficulties and illnesses and disturbances, and by itself may not be just because of a borderline personality disorder. So it's actually really important to understand context when we are making this diagnosis, and have to be really careful about how we phrase that.
And so in making this diagnosis, some of you might be familiar with the criteria as per the DSM-5. So specifically for BPD, as Kat's already sort of mentioned, it's a pervasive pattern of instability of interpersonal relationships, self-image and affect, and marked impulsivity that begins in early adulthood and is present in a variety of contexts, as indicated by 5 or more of the following. So these are 9 criteria, of which a person needs to meet 5 to receive a potential diagnosis of borderline personality disorder. The criteria: frantic efforts to avoid real or imagined abandonment, a pattern of unstable and intense interpersonal relationships, identity disturbance, impulsivity, recurrent suicidal threats, gestures or behavior, or self-mutilating behavior, affective instability, so reactivity in mood and emotions, chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, and in some cases transient stress-related severe dissociative symptoms or paranoid ideation. When we say that a person needs to meet 5 out of 9 criteria, lots of people will have different criteria making up the constellation of their diagnosis. So there can be a lot of variability within BPD. I think we sort of worked it out that there are something like 256 possible combinations of these 9 criteria. So BPD is certainly not something that presents similarly for everybody. And in fact, there can be a lot of different presentations.
And when we do think about that diagnosis of borderline personality disorder, I think we have to be really careful because, you know, it is associated with a lot of stigma, and we haven't got many slides about this today, but you know, a really big reason why a lot of our clients actually don't want to be diagnosed with borderline personality disorder is because of the stigma that they actually account. You know, we have to kind of recall that clients with BPD often utilize a high amount of services, even if they haven't received a formal diagnosis. And the diagnosis of BPD is a very challenging diagnosis. Not because it's resistant to treatment, but because of exactly the responses of healthcare providers. BPD is associated with a very, very high rate of self-injury and a reasonably high rate of suicide. And it does provide a lot of persistent psychosocial impairment. So clients that have BPD suffer tremendously and to very various degrees, sometimes visible and sometimes not so visible. But almost universally, clients who have BPD present with another comorbidity. And so, you know, at Spectrum, when we give these kind of presentations, these kind of talks, we actually call it the king or queen of comorbidities, because borderline personality disorder often presents comorbidly with either other personality disorders or other psychiatric disorders or substance use or trauma, or, you know, there's a very long ongoing list of difficulties that can make it actually really, really hard to treat.
I think that that aspect as well of the persistent psychosocial impairment is always worth pointing out because of the nature of some of the behaviours that are associated with BPD, specifically self-injury and suicide. Those often occupy a lot of our attention as healthcare professionals because the outcomes are obviously so severe. But what we also find is that people with BPD tend to struggle really significantly psychosocially. So they're often sort of unemployed, socially isolated, with a lack of meaningful connections in life. And even with treatment, where we see a reduction in self-injury and suicide attempts, we often see this persisting social impairment, which is can be quite difficult to treat.
And one of the things that our clients with borderline personality disorder tell us is that they have this unrelenting sense of emptiness, you know, this kind of feeling like they don't really know who they are, feeling like they have these intense emotions and feeling like they're not really the same and they can't fit in. And, you know, whilst as healthcare providers, we tend to work with clients to kind of address the more outward difficulty like self-injurious behavior, suicidal behavior, substance use, you know, outward behavioral disturbances. And a lot of the treatments kind of aim to reduce that primarily. That sense of emptiness, that chronic feeling of emptiness and aloneness, internal aloneness, is often persistent throughout treatment and can be one of the hardest aspects of that disorder to actually shift. And a lot of clients will tell us that, you know, that is kind of something that even after years of treatment can still sort of pop up intermittently, because of course there are periods when there might be a partial relapse or there are particular difficult circumstances that might bring about some of those experiences again. I guess important to kind of talk about, and we won't go into detail, is that there's actually a change of diagnostic criteria. So we've talked about the DSM-5, you know, with subcategories of the cluster A, B, and C. And really, globally, I think psychiatry is trying to move away from these subclusters, and they're moving to a diagnostic diagnostic system that really just talks about personality disorder, that looks at the severity of it, and the only specific personality disorder that will be left over will actually be borderline personality disorder. And a really big reason for that is because we actually have evidence-based treatments that can support clients in their recovery from that diagnosis. But so for those of you who are interested, to look at the ICD-10 and forward how that diagnostic criteria will actually change and the implications that will have for our clients and also for the services that we provide and deliver. But that's something for a different day.
Different presentation. So it's not the only thing we're interested in, certainly, but obviously we do have to talk about risk as well when we're talking about BPD, because it is associated with the risk of non-suicidal self-injury and suicide. These risks can be defined as low and high lethality. And they can also be considered both chronic and acute. So when we're talking about low and high lethality, we're talking about sort of means which carry a higher risk of serious injury or in some cases death. And when we're talking about chronic and acute, we're talking about long-term sort of stable level of risk, even if it is high risk, and acute risk being a short-term period of increased risk. There are other risks involved in with BPD, obviously, including substance use. Polypharmacy is a huge one. A lot of people with BPD have sort of potentially unsatisfactory interactions with health services, tend to sort of seek more and more support. There is a tendency within the medical field, I think, to prescribe medications as a way of trying to help somebody, and a person might start to have several prescriptions, often be prescribed several antipsychotics, an antidepressant, pain management medications, and things to help them sleep, all of which can contribute to a lot of metabolic issues. And as Kat mentioned, a lot of medical comorbidities with BPD as well.
So when we think about non-suicidal self-injurious behavior, I think in the old days we used to actually call that self-harm, but that can actually be experienced for many different reasons by a person. And I think it's important as healthcare professionals that we actually ask our clients and we don't just presume, because when we guess, when we think we know everything, we aren't open and we aren't willing to listen. And I think the active listening is actually a really important part. So, from asking our clients, we've kind of found out that a lot of the times clients or people with BPD use self-harm, non-suicidal self-injurious behavior as a way to punish themselves or as a way to actually express some internal distress that they're experiencing. The other thing they have told us is that this is a way to help them cope with intense experiences and or emotions. And sometimes when they feel nothing, when they feel numb and kind of disconnected, hurting themselves can be a way to actually feel something, which ultimately at that stage is better than feeling nothing. They have also identified that sometimes it can be a means to communicate their needs to somebody else, a very, very powerful need. And, as with everything, when we think about non-suicidal self-injurious behavior as well as suicide, Andy has already referred to briefly what we consider when we do an assessment of that risk that poses, then that can actually range from low lethality to high lethality. So, for example, cutting, may well be superficial, like a scratch or a razor blade, tiny cut, and not need any medical intervention. However, it's non-suicidal self-injurious behavior that involves cutting can also really involve high lethality risk, where a person is kind of cutting really deeply and kind of hits major blood vessels. So it's not that some are less intense than others or less severe. It always kind of depends on how that gets expressed and how the person uses that. And that will inform the risk of that.
So people with BPD are also amongst the highest risk groups for suicide. It's around 3 to 10%, which is a pretty confronting statistic when it's presented in that way. So a lot of people, I would say probably most people with BPD have an experience of suicidal thoughts that can be chronic and begin from an early age. And obviously a lot of people will also attempt suicide. So suicide attempts can include overdosing, which is quite common, hanging or strangling, poisoning, stabbing and gun use, or stepping in front of traffic or other sort of dangerous behaviour. As with non-suicidal self-injury, suicide attempts can range from low lethality to high lethality. For example, overdoses can be sort of low lethality if it's a small quantity of Panadol. It can also be high lethality if it's a large quantity of Panadol with alcohol and other medications. And obviously, there are certain methods that are much more lethal than others. So hanging and the use of firearms are almost always high lethality attempts.
Suicide is a frequent concern within mental health setting. However, and this sometimes is a little bit controversial, there really is no evidence-based method to prevent chronic suicidality. We said we won't really talk about risk assessments, but I think it is important to mention that when we do assess suicidality, we differentiate between acute and chronic. There can be an acute risk, there can be a chronic risk, and then there can also be an acute on chronic risk. And that's, I guess, the complexity of risk assessments. Sometimes additional community support or temporary hospitalization may actually be required to manage periods of acute suicidality that somebody experiences. However, for clients who experience chronic suicidality, attempts at sort of containing that person in hospital can actually be counterproductive and can actually, in fact, ironically increase the risk. Because really there's no evidence to say that hospitalization prevents people that are chronically suicidal in the long time to actually suicide. In fact, as we said, it might well increase it over time. And, that is a really difficult I think that's a really difficult thing to think about, because a lot of the times our clients do present to us and say, please put me in hospital, I can't cope, I can't manage these thoughts, I can't manage these urges, it's all just too much, it's too overwhelming, I need somebody to keep me safe. This kind of seeking of, I guess, external safety in order to not have to manage that. And when that is a chronic problem, then providing that external safety can then lead to a feeling of just not being capable afterwards, and then suddenly actually increase that risk. But that's a whole presentation, a whole workshop on itself.
But it's to reiterate that we know that treatment gains are made in the community, and that's the primary sort of place that we want treatment to happen for people with BPD. As Kat mentioned earlier, there are a lot of comorbidities associated with BPD. In fact, it's often referred to as the king or queen of comorbidity. The most common coexisting disorders are actually other personality disorders, which we don't really sort of see defined in much detail, to be honest. And Kat alluded to some of the changes to the ICD-11, but avoidant-dependent anachastic traits are quite common with people with BPD. Other psychiatric disorders are also very common, so depression, anxiety, substance use disorder, bipolar even, and then things like physical health disorders, so metabolic syndromes, chronic pain, PCOS. The way I tend to sort of frame these things is that these sort of make a lot of sense for people with BPD, that people are experiencing chronic stress and distress. That has a physiological impact on your body, like the levels of inflammation and chronic sort of pain. That's going to have an impact on your body. And that's sort of reflected in the reduced life expectancy of people with BPD, which is 20 years fewer than the general population, which is fairly significant. It's also important to mention that not everyone with a trauma history has BPD, but a lot of people with BPD do present with a history of trauma. So it's not essential, but it is very common.
And more recently, there's a move to also, this move towards complex PTSD, complex trauma, personality disorder. The boundaries between those diagnoses are becoming a little bit more and more blurred. And I guess a lot more research is actually needed to differentiate and then also define appropriate treatment methods, because often there is an overlap, that is this comorbidity, which can make it very challenging and very difficult to provide appropriate treatment to our clients.
So these are the key recommendations of the, I believe it's the National Health and Medical Research Council guidelines. So you can access these online, or you can also order a physical copy. Sometimes I find it useful to have this in a treatment setting, simply because it provides you with a basic outline of the recommended treatments for people with BPD. So the key recommendations are that BPD is a treatable condition. We do have evidence-based treatment for it. No drug, and by drug we mean medication, is licensed as indicated for BPD. So there is no medication that is prescribed for BPD. It's not to say that people with BPD won't be prescribed medications for other issues like depression, anxiety, and sleep disturbance and things like that, but nothing for BPD specifically. ECT, so electroconvulsive therapy, is not indicated for BPD. There's no evidence that it resolves BPD. There is no evidence that prolonged inpatient unit treatment is therapeutic or changes outcomes for BPD. And that psychotherapy is the evidence-based treatment with around a 65% remittance rate across all modalities. And that's the link where you can access those.
And I think it's important, this idea that, BPD is a treatable condition. Part of the stigma that's been around for many years is that people think, well, nothing works. There's just something flawed with the personality of the person. They just need to get over themselves and get on with that. And really, there's so much evidence out there that suggests that that's actually simply not true. With psychotherapy, common factor approach, and we'll talk about that in a little while, we can really provide a platform for people to make huge gains in their life and to really overcome some of those pervasive patterns that we've talked about earlier. And I think not offering that to people by either not making the diagnosis or by peddling other treatments that are only very mildly effective in terms of addressing one symptom, we are really actually doing a disservice to our clients, because having an understanding and having the ability to decide, yes, I want to treat this condition, I want to work on this condition, is really the first step. And I think we actually owe that to our clients, to make the diagnosis in a thoughtful way, in a collaborative way with our clients, and then to kind of together look at what are actually the treatment options out there.
So when to think about a diagnosis of BPD? So if you're working with clients and they're presenting with what we call pervasive emotion dysregulation, so that's an inability to regulate one's emotions. So that might manifest as somebody being presenting with highly expressed emotion, so significant sort of negative affect, sort of crying a lot or explosive anger, sort of an inability to manage one's emotions, recurrent self-harm or suicide attempts. High levels of impulsivity, persistent disturbance in interpersonal relationships, so lots of breakups with romantic partners, lots of fighting with family, fighting with friends, high service utilization, so presenting to a lot of different services, and frequent emergency department presentations. So not necessarily all of these, as we mentioned before, it's a very heterogeneous condition, but if you're working with a client and they're sort of presenting with some of these hallmarks, you might sort of begin to consider whether this person might have a personality disorder. Part of the reason we consider that, as Kat mentioned, is because we want that person to have access to good treatment if it's going to be helpful for them.
We thought we'd spend some time to talk about the relationship between substance use and borderline personality disorder, because it's actually quite commonly associated. When we think about functions of substance use, that can really include to allow a person to avoid strong or difficult emotions. And as Andy said, one of the hallmark signs when we should think about with our clients with BPD is that pervasive emotional dysregulation. We often will refer to that as this roller coaster ride. And sometimes clients use substances to manage that roller coaster ride, because it's really exhausting. Sometimes clients have told us that they use substances in order to punish themselves, to harm themselves, or sometimes also to seek sensations. Again, that when there's that numbness present, that kind of complete disconnect, using substances can sometimes be a really helpful way to kind of break that pattern, not unlike self-harm. We do know that substance use increases a person's risks by increasing their impulsive actions. It reduces the efficacy of mental health engagement. And of course, it produces a lot of physical health issues, financial pressures, and there's of course the risk of overdosing and death. So altogether, it really creates a higher level of complexity. And I think earlier when we talked about making the diagnosis of BPD, when somebody has substance use issues, we know, for example, that substance use increases impulsivity. We also know that impulsivity, for example, is a common feature of borderline personality disorder. So really, diagnostically, we have to actually be able to separate and to think about that. And that's why we have to really be able to take a good history, find collateral information from different sources in order to A, not misdiagnose somebody, of course, but B, also then not to withhold that diagnosis if it's actually appropriate. to make, because again, the only reason we want to make a diagnosis is so that we can actually provide a treatment that's helpful. This is the only reason we ever apply a label, so that it can then help us to find the appropriate steps to support that person.
And what the evidence suggests around treatment of BPD is that typically, while it's associated with a lot of comorbidities, treating the BPD first or concurrently with the other issues will be the most effective. So for instance, somebody with BPD and depression, treating the depression with antidepressants, for instance, will not really result in lasting improvement. It's actually important to treat the BPD. And if somebody's presented with BPD and substance use, then obviously we would advocate for treating both simultaneously. So some additional considerations when you're assessing for BPD when substance use is present. As Kat mentioned, ideally you want to have a longitudinal assessment and have a good sort of history, a bit of collateral information. Preferably assessing the person when they're not intoxicated or withdrawing, because you're likely to get a better picture of what the person is like when they're not using substances or withdrawing from substances. Something that we haven't really sort of mentioned as well, though, is that, if somebody is to stop using substances, some of these, like the underlying BPD symptoms might become more prominent as well. So that's something that we can also be conscious of. Considering the impact of substance use on the presentation, obviously, if that's contributing to their sort of impulsivity, disinhibition, reduced distress tolerance, and some of the social and economic factors contributing to crisis presentations. So, if somebody's got a serious substance use problem, they might also be at high risk of homelessness or financial pressures, and that might also be contributing to their level of distress rather than being driven by sort of an internal personality dysfunction.
So we thought we might spend some time talking about how to work effectively with clients with BPD. We've previously elaborated already that there's many effective treatments for borderline personality disorder. The most well-known of which is dialectical behavioral therapy. Often we call it DBT. However, there is an increasing amount of research that really indicates that no one therapy has actually provided to be superior to other forms of therapy. And now this idea of what we call a common effective factors that occur in all effective therapies are really what accounts for treatment success. And so therefore, therapy based on common effective factors is increasingly recognized actually as a valid treatment for borderline personality disorder. And the reason we are mentioning that is because there's such a huge demand for this specific therapy that are often very lengthy, very drawn out, years, and need a lot of funding. And if that is all that we focus on, then that potentially might mean that we are not looking at other therapies that could be provided to our clients in a far more brief environment. And so Spectrum has actually done quite a bit of research into more briefer forms of therapy as a brief intervention for clients with BPD. And I think we are seeing some very favorable outcomes from that.
Mm. And so what the research shows is that those common factors that make therapy effective for people with BPD are having a clear, structured treatment framework, a focus on the relationship with the clinician as part of therapy, so the clinician being active and the relationship being collaborative and cooperative, a focus on affect, so working with emotions as part of the therapy, exploratory interventions, so being curious, wanting to know more, presenting with a bit of a not knowing stance, which we'll come to, change-oriented interventions, so actually seeking to make changes as part of the therapy, having a shared formulation that is agreed upon by the clinician and the person, frequency and consistency of sessions, and the clinician having access to appropriate support and supervision.
So if all of those factors are present in therapy, then they are instrumental in the therapy being effective, and then can actually be implemented by any clinician within any therapeutic relationship. It doesn't have to be a BPD specific service. And I think the important part of that is that kind of really opens up the spectrum, so to speak, for people to actually seek therapy from other clinicians and from all kind of treatment providers rather than just from specialist services. And given the current shortage that we're facing of psychological service providers being available, I think that's actually really important because most certainly Spectrum receives far more referrals than we can actually manage in terms of providing treatment to. So
And the other thing that I would emphasize with that is that, you might not be involved in direct therapy with your clients, but you also have an opportunity to be therapeutic within those interactions. And our sort of next slide is talking about some of the things that you can actually be doing in each and every encounter, even if it's just a one-off sort of meeting with a person.
So every therapeutic relationship is an opportunity to model something to our clients. And I guess the principles that we know underpin a therapeutic relationships are the ones that we've highlighted here. We won't be able to talk about all of them because we really only have 1 hour and we really only have sort of 10 more minutes roughly to go. But we know that, for example, validation, acceptance, and curiosity has to be the underpinning of any kind of engagement with our clients that have BPD. If that is not present, then a therapeutic relationship will not function. Some of the other points are things like providing autonomy to our clients and holding a recovery-focused framework. And by recovery focus, we've already mentioned this earlier, the national guidelines can really provide a good overview of what that might look like. Psychoeducation, empowering our clients to actually understand what's happening, develop a framework for them to make sense of things and to move forward. The attachment and relationship is really important, and we won't have a chance to talk much today about attachment styles, but the way we have grown up and the way we have related to our parents or primary caregivers will, for example, have formed a blueprint of how we attach and connect in any kind of relationship. And so therefore, that's something that's really important to explore and to keep in mind when you are engaged in a therapeutic relationship. The other aspect in terms of interventions is to be able to tolerate and work with clients' distress as well as with our own distress, and being able to hold boundaries and limits.
So validation is really the key component of any therapeutic engagement. It communicates to the person that their responses make sense and are understandable in some way. Validation involves searching for, recognizing, and reflecting the valid part of the person's responses to events. It demonstrates acceptance of the person, their inherent ability, and that you're taking them seriously. So when we're talking about sort of validation, we're really sort of taking on what a person is saying to us and I'm struggling for words here.
Reflect that back, and it's really important that we validate what's valid, not what's invalid. So often, when our clients are distressed, they might be feeling really rejected, they might feel really overwhelmed, they might experience a lot of anger, they might experience a lot of distress, and that might be really hard to tolerate. And then they might be shouting at us, or they might punch the wall, or whatever might come about, or they might say, I'm going to kill myself because I can't cope with that. What we're not asking you to do is to validate those actions, those behaviors. But what we are suggesting is helpful is to actually validate the distress that the person is experiencing. You can say things like, I can see that you're really distressed. I can understand that you're really feeling overwhelmed, and it looks like it's all a bit too much. I'm wondering what we can do together to kind of manage that or to bring down that level of distress, or what I can say right now to support you in that. It's important that we validate emotions, not necessarily behavior. And by being validating, by being calm, by being open and curious, and not reactive, you're kind of saying to them, look, this is an emotion, this is an experience that you have, it will pass, you are a person beneath that, and that we want to return to that baseline of calmness, and that the person isn't their distressing emotion, and they aren't sort of this kind of screaming, shouting behavior, but that, their responses, their emotional experiences make sense, and that we can work with that.
So what a validation and curiosity look like in practice are, obviously attentive body language, asking open-ended questions, not sort of assuming, expressing warmth, good use of silence, so not sort of needing to fill every moment, allowing the person to sort of collect their responses. Curiosity, not knowing, we don't need to be the experts, and in fact sometimes that's unhelpful to present ourselves as experts. We can sort of model that, as Kat mentioned before, of not knowing that not knowing is okay, and that we don't need to solve everything immediately. We can work towards it over time. Reflective observations to confirm that we've understood and that we have it correctly, and obviously validation.
So sometimes, when our clients are very distressed, it can actually be really distressing for us as clinician. And so therefore, in order to help somebody else manage their distress, we first of all have to actually manage our own emotional responses. And once we've kind of done that, and that really takes great self-awareness and kind of, we often refer to that as co-regulation. Once we've managed our own responses, we can then focus on helping the other person's with their emotional responses. That really has to be done by being sort of empathic and by being non-judgmental and maintaining a sense of respect. And ideally not get sort of drawn into conflict or confrontation, when the person says, you don't care about me, I'm just a client, you don't think about me, whatever, it's probably not helpful when they're very distressed to get into an argument about how you do care about them and, how you do think about them. The key to engaging somebody who's emotionally distressed and dysregulated is always to help them bring their emotional intensity down to a point where they can actually start to think about it. Because when we are emotionally distressed, and this is not just our clients, but when we're in this kind of fight or flight response where we can't think, literally, this part of our brain, the front part of our brain that thinks goes offline. And it's the same that happens for our clients. So we really have to help them to kind of feel more in control. And I would also sometimes even name that. Sometimes I say to clients, I can see you're really distressed. I want to problem solve with you. I want to talk with you, but let's try and bring the level of distress to a point where you feel that you're actually able to be more in control, where you're able to kind of make different decisions, where you can think about things. This idea of remaining collaboratively, right? We are working together with our clients, and it's really important that we don't present ourselves as having the solution and being the expert, because that then creates that kind of over-reliance. We really want to get the person to kind of build up that sense of capacity in themselves. Often questions around boundaries and limits come up. Boundaries are really, really important. Limits are really important. The structure around boundaries have to include practicalities, like how often your sessions are, how long they are, what happens in between sessions, as a service you can provide, how long you're involved, what other support services are available, what your role is as part of the team versus other parts. Limits that you have, that can be personal limits in terms of length of phone calls or sessions, in between sessions, text messages or calls or whatever you do. But really the boundaries should be written down in an effective treatment and crisis plan, because then it's a shared document that you both have worked on collaboratively. And that structure of that treatment plan really creates a lot of predictability and safety and helps the other person to develop trust in that therapeutic alliance and relationship with you.
I think it's really important to emphasize as well that when we're setting limits with people, we're not doing that in a punitive way. We're not doing it to punish them for seeking more support than we're able to provide. We're actually communicating to the person what we're able to provide them with to ensure that consistency of response and consistency within the broader service setting that we work in. So obviously it's hugely beneficial to for services that are working with somebody with BPD to communicate so that they're all sort of providing consistent care to the person. In some cases that might involve meeting regularly with the care team. Obviously with everybody using Zoom and these sorts of technologies over the last couple of years has become a lot easier. And so we would say that, if you do have a complex person who has a lot of services involved, that should be happening. Communicating effectively with other service providers limits the ability for teams to split. It limits the ability for teams to be holding different ideas in mind and acting accordingly. So it's going to make your work a lot more effective. It obviously contributes to recovery. It aids risk assessment and intervention. And it communicates to the person with BPD that you're all supporting them.
Finally, so what to do if your client has symptoms that are consistent with borderline personality disorder? But firstly, I would suggest that you consider further assessment to provide diagnostic clarification. That further assessment can be made by any psychiatrist under Medicare 291 or 293. Your client can be referred to psychiatric triage, or if there's a particular level of complexity or severity, then, as previously discussed, a referral can be made to spectrum either by a GP or by a private psychiatrist. What's also really helpful is to discuss your formulation with your client in a kind of non-punitive and collaborative way, and to kind of phrase, well, look, this is maybe not my expert opinion. However, I have been wondering about this, and I have been thinking about this, and these are some of the guidelines. I find the McLean's questionnaire is a really helpful tool to use in your communication with your clients, and often not to present, I know what you have, and this is what you have, and so deal with it, but to kind of go about it in a forward and back conversation style. Not all clients that have borderline personality disorder will require specialist service input, and I think that's really important because there is often a demand for that in an ideal world that is possible. However, we don't live in an ideal world. We live in a post-pandemic world where there's a huge shortage of specialist services, but it's always the art of what's possible.
So some services that might be relevant for you in your work, obviously emergency services and 000. There'll be, well, hopefully not, but it's likely that there'll be situations in which you might have to initiate a 000 response if a client discloses to you an acute threat to their safety. If the threat is sort of not acute, but you're concerned, then you can certainly call the local psychiatric triage phone line and report it to them and ask that they follow it up with the client or with the community team. You could also consider area mental health. If one of your clients is presenting, in sort of unrelenting crisis, and it's becoming difficult for you to make any progress and get work done, they might benefit from case management from a local area mental health service to hold some of those sort of crises so that you can do the work that you're trying to do with the person. Psychology, as we mentioned before, psychotherapy is the primary mode of treatment for people with BPD. And so we would recommend that if your client has a diagnosis of BPD, then they should definitely be getting psychological treatment if they're interested in doing so. You can get that through a mental health care plan. There are also telehealth options available now post-COVID. Some NDIS programs have also funded psychology, although my experience with that is that it's been inconsistent. And then obviously Spectrum. So if you do want to make a referral to Spectrum, you can call intake and speak to one of our intake clinicians. Our eligibility criteria is that we work with people from 16 to 65 with a diagnosis of BPD or suspected diagnosis. But anyone can contact intake to discuss a client. If you just sort of want some information about what services might be available, or just sort of talk about what's presenting and what you'd like a bit of advice from that, then that's certainly possible. The one thing I would sort of say in relation to referring to Spectrum is to consider that we do have pretty long wait lists. So the two referral streams that we discussed earlier, the Medicare referrals and then the area mental health referrals. Our Medicare referrals are about 6 to 8 months for clients to get an initial assessment appointment. And then following that assessment, if they are offered treatment here, there could be another wait list sort of variable. It can be around sort of 6 months as well. So even if you are going to refer your client to Spectrum, it's important to communicate them that it could be a reasonably long wait. The reasons for that are simply that we get a huge number of referrals, that we cover the whole state. We can't take on everybody for treatment, unfortunately. So yeah, but we are certainly able to speak with you about how to, what other options you might sort of have and what other things you might be able to bring in when you're working with your client.
I'm conscious of time. We've run 3 minutes over in true German fashion. I'm aware it's 1:53 rather than 1:50. So the rest of those slides are really just about useful resources. And I wonder whether it would be helpful to get onto the questions that Naomi can manage fast.
Thank you so much, Andy and Kat. I am very aware that this is a time-limited session and there's so much material you've already covered. An incredible amount of information in the time available, but I know there's a lot more that can be covered. We'll try and answer a few questions live now before 2 o'clock. And then if we don't get to your question, then we will ask Andy and Kat if they're able to type a response to some people or to send a written response to some people. And just a reminder that the slides will be sent out after the webinar, and the webinar itself is being recorded and will be on the Turning Point website within a week or two. So I know there was so much information in there that I'm sure people mightn't have been able to grab everything first off. So please watch again and with a copy of the slides, and I'm sure you'll pick up a lot of information. So one of the questions that we've been asked by a few people is the difference between BPD and complex PTSD. Are you able to say a little bit more about about that?
So I might sort of decline to go into too much specifics about what the difference between those diagnoses are. I might just sort of cover a few key points, if that's all right, just because it is a really complex subject that the research isn't sort of decided on it. But a couple of points I would make are that as per the ICD-11 and what the research sort of shows is that they are distinct diagnoses. So a lot of people are using them sort of interchangeably, that, you know, the new name for BPD is CPTSD. It's actually not the case. It's referring to a specific diagnosis. There are certain features that are distinct from complex PTSD as BPD. So as the name would suggest, somebody with the diagnosis of CPTSD has to have had an experience of trauma. As we know, trauma can be, you know, defined in a lot of different ways. So that's something that I won't get into. But there are things like, you know, somebody with CPTSD presents with avoidant behaviors that you would associate with PTSD, for instance. So avoiding situations that are triggering for them, pervasive sort of poor self-image, whereas somebody with BPD, the self-image can sort of fluctuate in terms of positive and negative.
And can fluctuate in terms of context who people are surrounded by. Look, we know that a vast amount of clients that we treat here at Spectrum that we diagnose with BPD have also complex PTSD, and we know that a lot of people with complex PTSD have also got BPD. That doesn't mean it's the same thing, and I think that differentiation takes a lot more talk and effort and research, which is well beyond the 4 minutes that we've got left. But you know, there are people out there who put forward that it's exactly the same thing, and I guess Spectrum's position, and most certainly our position, is that they're distinctly different. Can co-occur, as we've talked about, as comorbidity, and treatment can overlap, but it is distinctly separate.
Thank you. We've had a question about whether or not clients are expected to be abstinent from drug use before being referred for a BPD assessment.
So the short answer is no. And obviously a lot of the people that attend Spectrum do have substance use issues. I suppose the only times in which I think we would consider refusing somebody who had a significant substance use problem was if it was going to interfere with their ability to engage with treatment. So if you were referring your client for treatment at Spectrum with the view that they would attend Spectrum for therapy and they're going to be substance affected, you know, constantly, then it's probably not a good time for treatment because it requires a level of, you know, lucidity to engage in that process. But if they're able to sort of, take days off the night before a therapy appointment or on that day, then certainly we'd consider that.
I think it's always worth discussing. I think most important, for clients to be referred, we do insist that they are not homeless. I think this is one of the key points that we don't often speak about. But, when somebody struggles with where to sleep every night and doesn't have, bases where they feel safe, it's incredibly difficult to conduct therapy. And I think it's also not fair because, if we accept clients for therapy when they're not in a good spot in their life for that, and by good spot meaning they're homeless, then, we give them an experience of therapy that's really actually tainted by the fact that they have to fight for survival every day. So, this is kind of one of the main, I guess, criteria where we are very mindful that, that's a big no-no. I'm aware of clients that have been referred and receiving treatments who are technically speaking homeless, but somehow managing it together, but it's really not ideal. And, we could argue that some treatment is better than none, but if there's this kind of continued crisis that's beneath that prevents people from attending, then it's actually not true. Then we're not really doing our clients a good service.
Thank you, Andy. That's been a wonderful presentation, but as you mentioned at the beginning, it really is, in the time available, just the tip of the iceberg or the foundation or the beginning of everything we need to know about BPD and working with our clients. So I would definitely encourage people to have a look on the Spectrum website or to contact Spectrum about the more extensive workshops that you run, because I know you do a lot of fantastic professional development in this area. So thanks again for this introduction, and people can get in touch with us and we will pass questions on to Andy and Kat if you have any questions following the presentation. So thank you again very much.
Thank you.
Bye-bye, everyone.
Bye.